Hello people, we want to look at in this video pneumothorax. What is pneumo? Air, that you know. Thorax, this chest cavity kind of a thing. But here it doesn't mean that the air is in thorax. It actually means air is in pleural space. Okay. So what is pneumothorax? Air in pleural space. Okay. So here you can see that the lung has collapsed because there is air in the pleural space. Okay, air. So this is pneumothorax. If there is fluid, you can call it other things like hydrothorax, etc. But here we will look at air in the thorax. Okay. So why does this happen? Okay. So let us look at the etiological classification. There is something called as primary and secondary. Secondary means there is some lung disease. Okay. Primary means there is no lung disease. That much you can remember, right? So secondary means what type of lung diseases? Because of some chronic obstructive pulmonary disease, that is emphysema, right? That is COPD. That's what they are saying. Tuberculosis, asthma. See, they have written in this table if you are not able to understand from where we are reading. Tuberculosis, asthma, lung abscess, pulmonary infarct, lung cancer, all forms of fibrotic and cystic lung disease, all this will be secondary. So these will be the secondary causes of pneumothorax that will become secondary pneumothorax. Now coming to primary, the lung is totally fine. There is no disease or anything. So there is some bleb or something which is bursting and causing this pneumothorax. Okay, but they're saying the lung is absolutely fine. Okay. So that's what you should understand about primary pneumothorax. Okay. So all these are coming under spontaneously. Spontaneous only itself is primary. Spontaneous itself is secondary only. Suddenly it will happen. Okay. Traumatic. So one is spontaneous, by itself it is happening. Traumatic is because of trauma. Okay. So you have understood what is spontaneous and traumatic. Traumatic is you are getting a trauma. Somebody is iatrogenically piercing or something is happening. Then only it is happening traumatic. But spontaneous is nobody touched you. You should understand that, right? Okay. So pneumothorax etiological classification you have seen. Now there is yet another classification. Look at this. This is the spontaneous pneumothorax itself types. So this is the types in the spontaneous pneumothorax. This can be primary or secondary. You understood, right? But here there's no trauma. So that's what you should understand. Spontaneous pneumothorax. So here, what are we looking at, guys? Spontaneous pneumothorax types. Okay. There is this closed type. Closed means what happens? The air enters like this, right? And then the lung deflates, correct? Now when the lung deflates, this opening which was there, it will seal off. So the air remains here, okay? So the airway and the pleural space, there is no communication anymore. So this is closed type, okay? And the pressure here will be negative. So that's why they have written here, mean pleural pressure is negative, okay? This is the closed type, okay? Is this understood? Now let us go to the what will happen to this type also. They are telling here. They are saying that this there is spontaneous resorption of air. So this air will get resorbed. So this will resolve itself. Looks like there is re-expansion of the lung after this gets resorbed after a few days. And in this, infections also don't happen because there is no communication, right, anymore. So this is closed type. We like the closed type. What do you say, people? Actually, we don't like anything, but anyways, of those three. Now let us go to the next one. This one, what is happening? The air has come here, right? The air has come here, right, into the pleural space. So there is a broncho-pleural fistula in this case. So air is coming and air is exiting also. So air is coming, exiting, enjoying its life, you know. And this is the open type. Here the atmospheric pressure, same thing you can say. The pressure here is neither negative positive, it's the same as the atmospheric pressure kind of a thing. Okay. So here the problem is that there can be infection. Imagine there's a fistula here. It's communicating, right? So there will be infection. This can lead to empyema. What will it lead to? Empyema. Empyema. Pus in the pleural space. Okay, not at all, we don't like this, right? So an open pneumothorax, this one is more common in whom is this open type common? It is more common if there is a rupture of a tuberculous cavity or a lung abscess or an emphysematous bulla. Okay, so in those cases an open pneumothorax can be there. If you're smoking a lot, you have emphysema, you have an emphysematous bulla, that can rupture and lead to this one. Okay, so be careful, it can go to empyema. Now let's go to the third one. Tension pneumothorax, our favorite. It is also called as valvular. You know why? Because the air is able to enter, but it can't leave. So this is acting like a valve, one-way communication. Okay, the communication between the airway and the pleural space acts like a one-way valve, allowing the air to enter the pleural space during inspiration but not go back during expiration. So what will happen? The pressure here will increase. So there is going to be positive pressure here, and this will cause a shift of the mediastinum to the opposite side. Okay, so there is compression of the normal lung. So imagine if it is compressing onto the left side, what will happen to the heart? The heart also will get compressed. No, but if it's going away from the heart, it will be nice, right? So we don't like this one because of empyema, and this one because if it's on the right side, it is going to push to the left side and cause cardiovascular compromise, right? So yes, that's it. Then this is the three things. We are done with the types of pneumothorax. We're done with the types of spontaneous pneumothorax, right? So I hope you have understood all this closed type, open type, tension pneumothorax, everything. Now let us look at the clinical features. What do you think these people will come with? Sudden and onset, one-sided pleuritic chest pain or breathlessness. Sudden and onset, one-sided pleuritic chest pain, breathlessness. Okay, if they have underlying lung disease, the breathlessness will be severe, obviously. They have other issues. And because they have an underlying lung disease, this issue is resolved spontaneously. Now what you do, you will put your stethoscope and hear the breath sounds. If it is a large pneumothorax, what will happen? You will not be able to hear breath sounds. There can be decreased or absent breath sounds, right? Let me show you this. This is the image. You can see here how the lung has collapsed. The collapsed lung is here, and here you can see a lot of translucency. So this is the right side pneumothorax. So if you keep your stethoscope here, what will you hear? There will be absent breath sounds. Okay. So that's what they are saying here. Decreased or absent breath sounds on that side. Okay. And when you percuss, you will get resonant or hyperresonant, right? You'll get resonant or hyperresonant. Resonant, okay, normal only. But hyperresonant you can give. There's more air, right? Here, there's more air. So when you percuss, you'll get resonant or hyperresonant, okay? In tension pneumothorax, what will happen? If there is tension pneumothorax, let's mark here. If it is tension pneumothorax, progressive breathlessness. This is increasing and increasing. His breathlessness is going on increasing. Why? Why is the breathlessness going on increasing? Because the air is coming in and not exiting, and is pushing the mediastinum to the other side. The pressure is increasing in the pleural space. So there is progressive breathlessness. This is the word you will write. Marked tachycardia, hypotension. Hypotension and all is very bad, isn't it? Cyanosis. Because what is happening? The heart is getting compressed, right? Heart can get compressed. Tracheal displacement away from the site. Tracheal displacement, yeah, we know, to the opposite side. Yeah, we know this. Tracheal displacement. All this we know already, isn't it? Then, sometimes they are saying this tension pneumothorax may not show a mediastinal shift if there is a malignant disease or a scar which has splinted the mediastinum. So you should understand this, that if the mediastinal shift can happen, then okay. But if there is some tumor sitting there, a malignant disease or a scar sitting there, and this is trying to push the mediastinum, and mediastinum is not going to the other side, you understand here, right? For you and me, if there is a tension pneumothorax, it will push the mediastinum, fine. But imagine there is a guy who has a tumor, malignant disease here or some scarring here. It will try to push, but it cannot, right? So you should not always think about mediastinal shift. Okay, that's what they seem to be trying to tell. So basically, you should listen to the progressive breathlessness. Okay, progressive breathlessness. This resonance in resonant percussion note, hyperresonant percussion note, absent breath sounds. These only should be a clue, right? Then these 4 points are also clinical features only. So look at them. Okay. Inspection, you will see that that person is in pain, tachypnea. He has some deflation reflex. Palpate, when you palpate the side, or when you just see his lung expansion or chest expansion on right side, it will be reduced. When you percuss, resonant, hyperresonant on the side that there is pneumothorax, auscultation on the side that there is pneumothorax, you will see absent breath sounds. Okay. Then if there is a tension pneumothorax, you can see a deviation of the trachea to the opposite side. You can also see hypotension and tachycardia. Okay. So what are the additional signs of pneumothorax, tension pneumothorax? In addition to the pneumothorax symptoms, you will have deviation of the trachea to the opposite side, tachycardia and hypotension. Okay. But this deviation of trachea to opposite side may not be there in a malignant or a scar, etc. So now let us come to investigation. Okay. Investigation, what and all you will do? You will do X-ray. Very good. You already have seen it here. So you can see here how there is increased translucency, right? The lung markings, there are no lung markings here. But here you can see the collapsed lung. It's so clearly visible actually. Right? So in case there was some large pre-existing bullae, you should be able to differentiate it. Okay? You should not think that it is pneumothorax, a large pre-existing bulla. So you will do X-ray, then you will do, what else you will do? CT. What are we looking at, people? Pneumothorax, okay. CT is used in difficult cases, okay. X-ray may show the extent of any mediastinal displacement. It can show mediastinal displacement also. It can reveal any pleural fluid or underlying pulmonary disease also. It can help in. Then we'll do X-ray only. What do you say, people? Yay, people, we have reached the management. Now pay attention here, okay, of what? Pneumothorax. So here they're telling you the management. They've given off one flow chart. So we will look at flow chart easily and try to understand. What do you say? So is there mediastinal shift? Is there a media? Answer is yes. So if it is yes, what will you do? What are they planning to do? You put a chest tube, is it? Intercostal tube drainage attached to underwater seal device. Oh, that is same. Have you seen that? Do you know how to do this procedure, guys? Even if there is fluid, also they can do this. But here, because it is air, right? Then you will have to put some underwater seal, okay? For collecting the air, and the air shouldn't come back. So this is about tension pneumothorax. First thing you want to do is remove the air, okay? Now there is no mediastinal shift. Is there some chronic lung disease in this guy? Yes. If there's some chronic lung disease, then again chest tube. Okay. Then look at other things also. Whatever happens, is he greater than 50 years, then again chest tube. Okay. Then what else here? When are they putting chest tube? Greater than 2.5 liter air aspirated or pneumothorax persists, then chest tube. Okay. For most of them, it's chest tube only. Only if there is less air, okay, if there is less air, if the person is young, then they are doing some percutaneous needle aspiration. What is this percutaneous needle aspiration? Do you know? This one. So needle decompression. See, they're just putting a needle here. Second intercostal space, right? They're putting it and they are going mid-clavicular line. And they will aspirate the air, okay? And still a lot of air is coming. Again, they are talking about intercostal chest drainage tube, okay? So how will you do also? So nicely this textbook is telling Davidson how to do. See here, aspirate the how do you aspirate this? Aspirate with the needle, right? Second intercostal space anterior in the mid-clavicular line using a 16F cannula. That is 16F is what gauge I've heard. Okay. And this, okay, you can remove a lot of air. More than 2.5 liter of air are removed. Okay. Coming to the intercostal tube, where to put that? Fifth intercostal space, right? See, this aspiration, this textbook has given, but for chest tube, they didn't exactly tell the location. Okay, this is between the fourth and fifth rib, and it is actually axillary, right? So this is between the fourth or fifth, or between the fifth and sixth, just behind the pectoralis chest muscle. Okay, this is what is the intercostal drainage. So you'll use a scalpel, right? And you'll cut, and then you will put a tube. You'll actually widen it in a clamp, and then you'll put a tube, isn't it? Again, this procedure we have done in cadaver. You will put a gloved finger into the incision and then put the tube. So we are done with pneumothorax, guys. Hope you understood something. Now let us take a recap. So in this video, we wanted to look at pneumothorax because it is nothing but air in pleural space. So the pneumothorax, you can see here, there is air in the pleural space causing the lung to have collapsed. So there are two types. You have the primary and the secondary. In spontaneous, actually, you have two types. In spontaneous, you have two types. That is primary and secondary. Other than spontaneous, what are the varieties? Traumatic. Okay, spontaneously, Spontaneous means without trauma it happens. Secondary means there is some underlying lung disease like COPD, emphysema, tuberculosis, asthma, lung abscess, pulmonary infarct, lung cancer, all forms of fibrotic or cystic lung disease. Okay, that will cause secondary spontaneous pneumothorax. Primary means there is no lung disease, there is some bleb which is rupturing, okay, without trauma. Trauma means because of trauma, iatrogenic, etc. injury. Now, under the spontaneous, that is primary, secondary, you have three types. You have the closed type, open type and tension type. Closed type means there is the air entered and then the lung collapsed. When the lung collapsed, that opening got sealed off. So, the air is trapped here and it cannot leave. Here there will be negative pressure, they are saying the mean pleural pressure negative, and this air will anyways get absorbed, reabsorbed, and this person will recover. He has a chance of recovery. Okay, and there is no chance of infection because there is no communication. Now coming to the open type, there is communication, air can enter, air can leave. So the pressure will be like atmospheric pressure, you can say. And here what will happen, there can be infection because it is open, right, and is going in and out. So this person can go into empyema, infection. Then coming to tension pneumothorax, here what is happening, the air is entering but it can't leave. Okay, so what will happen, as he inspires, more and more air is getting accumulated, and the pressure is increasing. So there's positive pressure here, and this will cause a push of this mediastinum to the opposite side. So there can be mediastinal shift. Sometimes if there is malignancy or some scarring, then it cannot push. It will be trying to push, but it can't push. In these people, there can be hypotension and tachycardia. These are very important things. In tension pneumothorax, hypotension and tachycardia, because the heart is getting compressed. Okay, so this is also called as valvular because the air can enter but cannot leave. So this is like acting like a one-way valve, right? What will be the clinical features? Mostly they will be male. Okay, spontaneous is more in young age, and the secondary, so the primary is in a young age and secondary can be in old age because of lung disease. Now coming to clinical features, sudden onset unilateral pleuritic chest pain or breathlessness. If they have lung disease, then the breathlessness can be severe, and this pneumothorax will not resolve spontaneously if they have underlying lung disease. If there is a large pneumothorax, he will have decreased or absent breath sounds. When you percuss, you can get resonant or hyperresonant on that side. If there is tension pneumothorax, there will be progressive breathlessness, remember, with tachycardia and hypotension. These are the things you have to write about tension pneumothorax if they ask you in the exam, right? They can also have cyanosis because their heart is getting compressed. You can understand the pressure is going on building in a tension pneumothorax, right? There can be tracheal displacement, but if there is a malignant disease or scarring, then the mediastinal shift will not occur. Okay. Then other things that you can see in clinical in features, inspection, you will see tachypnea, pain, deflation, reflex. Palpation, you will see that there is less expansion on the right side. Percussion, you will see that there is percussion, you will see that it's resonant or hyperresonant on the side of the pneumothorax. Auscultation, you will see that there is absent breath sounds on the affected side. Tension pneumothorax, you will also see mediastinal shift to the opposite side, tachycardia and hypotension. Okay. Now coming to the investigations, you have the X-ray that you can do. Investigations, you can see in X-ray that there will be increased translucency. You should differentiate it from large bleb, right, which can also have air, isn't it? So you should be able to differentiate it from large bleb. Sorry, not bleb, bulla. You should be able to distinguish it from bulla. This is bulla. You can see here, these are air-filled cysts, bubble-like structures. They are large in size, larger than 1 centimeter in size. So you should not confuse them with a pneumothorax. X-ray will also show you mediastinal shift. It will show you, what else it can show you? It can show you a lot of things. Okay, X-ray. It can show you if there's any underlying lung disease. It will show you that if there is any pleural fluid also it can show you. Okay. It can show pleural fluid, lung disease and mediastinal shift. Okay. Then CT also you can use, but X-ray itself they are so happy with. Okay. Management, how will you manage? Look at this. You will check if it is a tension pneumothorax. If it's a tension pneumothorax, you will put intercostal drainage tube between 4th or 5th intercostal space or 5th or 6th intercostal space in the side, right, axilla. So this is where you will put it, and first you will use a scalpel, then you will use a forceps to widen the gap, put your gloved finger inside, make the gap, and then put a chest tube. And this chest tube, we will have to put a water seal so that the air doesn't come back, okay, into the lungs, okay. So that is the intercostal chest drainage tube, okay. They are telling here intercostal drainage tube how to do, okay. So mid axillary line, then there's a valve, then you should attach it to the chest wall, okay. A drain should be removed the morning after the lung has fully re-inflated, okay. Continued bubbling is, if it is there, then this is an indication for surgery, okay. Supplemental oxygen may be a resolution. You can give oxygen as it accelerates the rate at which nitrogen is reabsorbed by the pleura. Then coming back here, if it is a young guy who has little little pneumothorax, and if he is not having any lung disease, you can do a percutaneous needle aspiration, which they have shown here in the second intercostal space anterior in the mid-clavicular line, okay, using a 16F cannula. This is for a young guy with no tension pneumothorax, no lung disease, with pneumothorax which is not so significant, okay. These closed people, no, they should wait for it to get reabsorbed, because we told you, right, this will get reabsorbed and the lung will expand. They have to wait. They should not go anywhere, and then this air will expand and it will cause more problem. Ask them to wait for 1 to 2 weeks, okay. Then if there is spontaneous pneumothorax, this guy is having again and again. It can happen, okay, that once they have pneumothorax again, it can happen. So how will you treat this? There is something called a surgical pleurodesis. This is all you have to write in the exam. Surgical pleurodesis means what, you know? This is a very strange thing. Pleurodesis means involves putting something between the this in pleural space. You put something like gum. That is pleurodesis. So, saying that you're trying to stick your lung to the wall of your chest and prevent further collection of fluid or air in the space. Pleurodesis. What a strange thing, right? So it's putting like something like a gum. Actually, they're saying it's a mild irritant drug put in the space between your lung and chest wall, the pleural space. Pleurodesis. Okay? So that's it, guys. In this video, you have looked at pneumothorax. Bye-bye.